The following podcast is part of a certified educational activity titled Preparing Your Practice for Amyloid-Directed Therapies in Alzheimer's Disease: Key Strategies to Enhance Early Diagnosis and Optimize Management. Access the entire activity and complete the post-test at peerview.com/CXX860. Downloadable slides and practice aids are also available.
Hello and welcome to PeerView. I'm Dr. Jared Brosh, a neurologist at Indiana University. Today we're going to be talking about preparing your practice for amyloid beta-directed therapies. This talk includes key strategies to enhance early diagnosis and to optimize Alzheimer's disease management. There are quite a few gaps in the management of Alzheimer's disease. Many of this involves an underdiagnosis of early-stage Alzheimer's disease and using biomarkers to be able to do that. There is suboptimal engagement of shared decision-making, underutilization of amyloid beta-directed therapies, and underrecognition of amyloid-related imaging abnormalities. During this presentation, we're going to cover several topics, including identifying patients who would benefit from biomarker testing and choosing the best test, navigating the practical challenges associated with integrating these amyloid beta-directed therapies into your clinical practice, and selecting the right patients for treatment and how to deliver those therapies safely and effectively. Module 1 is using validated and emerging biomarkers to confirm a diagnosis of early-stage Alzheimer's disease. There are a lot of benefits to early detection and a biomarker-confirmed diagnosis. A biomarker-confirmed diagnosis can validate patient and family concerns. It enables patients to participate in their own care planning and empowers them to make early lifestyle changes, which we've seen some growing evidence for recently in the ability to slow and prevent progression of disease. We can facilitate more education and personalized support services. We also know that biomarker confirmation is critical for qualifying individuals for amyloid beta-directed therapies. There are also a wide variety of clinical trials that target other modalities that may be critical for the future treatment of Alzheimer's disease, and identifying early patients is critical for involvement in these early-stage clinical trials. In 2018, a research framework for biomarker and Alzheimer's disease classifications was created. This framework involves the ATN classification, where A stands for amyloid, T for tau, and N for neurodegeneration or neuronal injury. A variety of profiles was created so that we can better understand which profiles are more characteristic of Alzheimer's disease pathologic changes, which may be a part of a continuum of disease, and others which may represent non-pathologic change in terms of Alzheimer's disease. These biomarkers are related to our knowledge that there are early changes in amyloid beta that occur many years, upwards of 20 to 25 years, perhaps, before a person ever manifests their first clinical symptoms. After amyloid, we see elevations in phosphorylated tau, and then ultimately in PET-related changes and in more broad neurodegenerative changes, such as those seen on atrophy on an MRI scan, or elevations in other blood-based biomarkers like neurofilament light chain. In 2024, a revised criteria for biomarker-based diagnosis and staging was created. And in this revised criteria, one can see the addition of plasma-based biomarkers into this milieu. The core 1 biomarkers are ones that many of us are familiar with, including amyloid PET, spinal fluid-based biomarkers, including amyloid ratios, phosphorylated tau, and total tau, and now the addition of plasma-based biomarkers, including p-tau 217, 181, and a variety of others, including ratios of tests. There are core 2 biomarkers, which are used less frequently clinically, but are growing in their availability, which might also help with identification and disease classification. Other biomarkers that are non-specific to Alzheimer's disease but indicate neuronal injury and the operations of the microglia and central nervous system immune system functioning. And finally, other biomarkers of non-Alzheimer's disease co-pathologies. We know that there are a variety of advantages and limitations to these three different modalities of Alzheimer's disease biomarkers. PET scans, which have long been considered the gold standard of neuropathological diagnosis in living individuals, has limitations in terms of capacity, availability, cost, and in radiation exposure. However, there are definite advantages to this modality, including the ability to both look at the regional distribution of amyloid and to be able to now quantitate the amount of amyloid that's present, as well as quantitate disease response to therapy. Spinal fluid is certainly more invasive, but may also be lower cost. It has advantages in that we collect all of the specific biomarkers of ATN criteria with a single test. An amyloid PET scan collects only the A portion of ATN, whereas spinal fluid collects an amyloid ratio, a phosphorylated tau measurement, and a total tau measurement, which includes all aspects of ATN, which may help delineate patients more clearly. Plasma-based biomarkers, on the other hand, are incredibly convenient. They can be used in any setting, have wide availability. However, their validation in a wide variety of patients in a variety of different clinical settings is not yet complete, and we hope with time these biomarkers will be validated in all of those settings. To dig down a little deeper, amyloid PET scans are now in many cases able to be quantitated using FDA 510K cleared software, which measures centiloid values. These centiloid values have been shown to have very high concordance with expert visual reads, making these scans and their test results more applicable and more accurate in our patients. Additionally, this centiloid reading can help us make decisions about early termination of amyloid targeting therapy and to understand the response of an individual to those treatments. There is a set of appropriate use recommendations for amyloid PET that have been published. See the reference below. But this primarily involves the early identification of Alzheimer's disease in individuals with mild cognitive impairment that can help with diagnosis and qualification for amyloid-targeted therapies. Spinal fluid biomarkers have been shown to be very accurate compared to amyloid PET. Individual spinal fluid biomarkers are not quite as accurate as ratio-based spinal fluid biomarkers as seen on the right-hand curve. With these ratio-based biomarkers, we see an area under the curve around 0.94, making these very accurate specificities. Spinal fluid biomarker testing also has appropriate use criteria. These are similar situations to the appropriate use criteria for amyloid PET and involve early identification of Alzheimer's disease pathology in individuals with mild cognitive impairment and the ability to qualify individuals for amyloid-directed therapy. Recently, the FDA has cleared the first blood test for diagnosing Alzheimer's disease. This was done in May 2025 and granted clearance for an amyloid and tau plasma ratio test. This test is indicated for adults age 55 and greater who are exhibiting signs and symptoms of Alzheimer's disease. This is not intended as a screening or standalone diagnostic test, and the results should be interpreted in conjunction with a patient's clinical additional information. In a small group of individuals, this test demonstrated excellent positive and negative predictive values. Blood-based biomarker tests are designed to have a two cutoff approach. In this design, a high cutoff would potentially confirm amyloid pathology, making it very likely these individuals would have a positive PET scan. A negative cutoff would essentially rule out amyloid pathology and have a high concordance with a negative amyloid PET scan. This does leave a 15 to 20% group of individuals and test results that are in an intermediate range and would need further clinical evaluation and understanding. There are clinical practice-based guidelines and recommendations for blood-based biomarkers that have recently been published. These guidelines establish the sensitivity and specificity cutoffs needed for these tests to be triaging tests and confirmatory tests. Currently, these recommendations apply to patients being seen in specialized care settings. However, eventually, these guidelines will address the use of these tests in primary care settings. The biggest barrier to that is that blood-based biomarkers have not been used in a wide variety of settings and in a pragmatic approach to clinic patients with a wide variety of comorbidities. Hopefully, over time, we will see an increase in the amount of validation of these blood-based biomarkers and their use across a variety of settings so we can better understand the use of these in clinical practice. One of the big questions that you should be asking at this point is a clinical Alzheimer's disease biomarker test right for your patient? This is always a shared decision-making model that we use for biomarker assessments. In certain individuals who may be far advanced in their disease process, a blood-based biomarker or other biomarker is really not necessary and would not impact your treatment of an individual. Therefore, judicious use and understanding of what those risks and benefits might be, the invasiveness of a specific test, and how it changes management are all very important considerations. This table shows a variety of patient-specific factors that might help influence your decision, including a patient's concern about radiation, claustrophobia, needles as an example, or a person's desire to have the most accurate test as a few examples. Here we have a case that I'd like to go over that's meant to be thought-provoking. Patient 1 is Florence. She's a 71-year-old female who was referred from primary care for progressive memory and cognitive difficulties for about the past year. A mini mental examination is 23. She has a medical history of hypertension, diabetes, arthritis, and a BMI of 42. She's on lisinopril, metformin, and aspirin, and she has MRI findings which show diffuse atrophy, but also moderate to severe small vessel ischemic disease with 2 lacunar infarctions. A plasma-based biomarker test was inconclusive. There are quite a few discussion points that one might consider with this individual. One might consider this person to have a vascular-based form of cognitive impairment, specifically since her blood-based biomarkers came back indeterminate. However, her testing might indicate potential eligibility for amyloid-targeted therapies depending on how severe the small vessel ischemic disease is on the MRI, and she might require follow-up testing. All of these would be considerations and things that one would discuss with this patient before moving forward down a treatment pathway. Module 2, Targeting Amyloid in Early-Stage Alzheimer's Disease, Evaluating the Clinical Evidence and Optimizing Patient Selection for Treatment with Amyloid-Beta-Directed Therapies. Amyloid-beta-directed monoclonal antibodies are the first disease-modifying therapies approved for Alzheimer's disease. These treatments are well known to substantially reduce the amount of brain amyloid within 12 to 18 months of treatment, and a majority of individuals who undergo treatment for 18 months show a complete loss of amyloid such that an amyloid PET scan becomes negative for amyloid pathology after treatment. These clinical trials, phase 3 clinical trials that led to FDA approval, also showed an impact on clinical decline. Many of the measurements, which were both functional and cognitive measurements, showed a slowing of disease progression in individuals treated with amyloid beta monoclonal antibodies. There are a wide variety of amyloid beta species that are both soluble and insoluble. The drugs that have been developed target different forms of these amyloid beta species. Some of them are more targeting towards soluble forms of amyloid, and others to more insoluble forms of amyloid, as shown here. This may have an impact on the efficacy and speed with which plaques are removed, and may also have implications in terms of the amount of ARIA that's present, and also whether or not treatment is required after plaque removal. Clarity AD was a phase 3 study which proved lecanemab efficacy. In this study, which many of you are familiar with, there was a significant loss of amyloid over an 18-month period, where many individuals dropped below the threshold for detection. There was also an impact on both spinal fluid and plasma-based amyloid biomarkers. In terms of efficacy, multiple measurements of both cognitive and functional decline showed a slowing of clinical progression. One of the measurements that I'd like to point out is the Clinical Dementia Rating Scale Sum of Boxes score, as this is a measurement that was used across almost every clinical trial involving this type of medication. At the end of 18 months, about a half a point difference in the CDR Sum of Boxes was seen. This is, for those of you unfamiliar, a combination test which involves both a cognitive and functional component, therefore representing both a cognitive and functional slowing of progression. Biomarkers, as shown on a previous slide, also showed downstream biomarker modification, including phosphorylated tau, measurements of microglial activity, as well as some measurements of neurodegeneration. An open-label extension study, which was published in the past few weeks, this efficacy has shown benefit through 48 months of treatment. And if we look at the original 18 months of therapy with about a half a point difference in the CDR Sum of Boxes, this grows to approximately a 2-point difference in the Sum of Boxes scores over 48 months. This represents a substantial and significant difference between those treated and those who are untreated. Recent data looking at a subgroup of individuals that have low tau, indicating potentially that these individuals are at the earliest stages of Alzheimer's disease, showed a substantial number of people who showed no decline in their CDR Sum of Boxes scores over 48 months, and an also large population of individuals who showed improvement in their CDR Sum of Boxes score over 48 months as well. This is further evidence indicating that the early identification and early treatment of individuals with Alzheimer's disease may have a larger impact than those treated later on in the stages of Alzheimer's. TRAILBLAZER-ALZ 2 was a phase 3 study which proved that donanemab significantly reduced amyloid and also showed a substantial clinical impact. On this slide, we can see a robust removal of amyloid as measured with amyloid PET over time, and we can also see in this slide, which was a unique aspect of the TRAILBLAZER study, that they immediately divided individuals and monitored treatment in a low to medium tau group and in a combined group, showing a more substantial decrease in biomarker-based engagement in the low tau group. When we look at the clinical endpoints, we can see a more robust change in individuals who have low tau as opposed to those in a combined population, ultimately over the course of 18 months, showing a difference in the CDR Sum of Boxes score of over a half a point and close to 0.6 at that point. Long-term extension data was published within the last few weeks and shows over monitoring of 36 months or 3 years a continued improvement and a continued divergence in the CDR sum of boxes score between those treated with donanemab and those who were not treated. Infusion reactions are an important part of treatment with amyloid beta-directed therapies. In the Clarity AD study, approximately 26% of individuals had a mild to moderate infusion reaction. This occurs early on in the treatment and can occur for several hours after the infusion. These infusion-type reactions typically resolve within 24 hours and are often able to be managed at home. Symptoms can include a viral prodrome, which includes things like fever, chills, headache, and a variety of other symptoms listed below. In clinical practice, when someone suffers from an infusion reaction, we may apply additional pre-treatment medications to the first few infusions to help patients get through these initial type reactions. Although severe reactions are rare, one should be prepared with bronchodilators, oxygen, and epinephrine if needed for an anaphylactic type reaction. Amyloid-related imaging abnormalities are some of the most important potential side effects of amyloid beta-directed therapies. Many of you are familiar with these types of side effects, and they are primarily broken down into two subcategories: ARIA-E, which involves vasogenic edema, and ARIA-H, which involves microhemorrhages and hemosiderosis. These side effects are easily detected on MRI scans without contrast, but need to be reviewed in the setting of an experienced neuroradiologist. ARIA carries with it some risks. However, most ARIA is asymptomatic. It is only captured on surveillance MRI scans. There are algorithms through which we decide whether or not dosing can be continued or whether it needs to be paused. However, assessment for clinical symptoms is absolutely key to making treatment-based decisions. When symptoms are present, they are typically transient and they resolve on their own. However, serious and life-threatening events can occur. It's important to understand the risk factors for ARIA and how to manage the side effects effectively. We know that ApoE4 is one of the largest risk factors for developing ARIA. We know that the presence of any form of underlying cerebral amyloid angiopathy, the severity of cerebrovascular disease, and the control of other vascular risk factors have an impact on whether or not a person will have ARIA and the severity that they might have in treatment. Rates of ARIA can be broken down by ApoE4 genotype. These are more easily compared in the phase 3 studies between lecanemab and donanemab. Columns showing the Clarity AD study and the TRAILBLAZER-ALZ 2 study are here and show the difference between the placebo groups and the treatment groups broken down based on ApoE4 genotype and their impact on ARIA-E and ARIA-H. Shown on the far right is evidence from the recently published TRAILBLAZER-ALZ 6 study, where a small group of individuals was followed using a modified titration schedule for donanemab. This modified titration schedule showed an improvement in ARIA-E rates across all forms of ApoE4 carriers. One must keep in mind this is a smaller group of individuals. ARIA-H rates are also shown in that column as well. Amyloid beta-directed therapy has specific dosing schedules for each drug, and each drug also has a specifically prescribed ARIA monitoring. These safety MRIs are critical to have ordered at the appropriate times, and when patients miss an infusion, these MRI schedules need to be modified. This type of monitoring is critical to the performance and the safety of these drugs, and therefore, when one designs a practice to treat individuals with amyloid beta-directed therapies, these type of logistical changes need to be considered. The rationale for maintenance dosing with lecanemab has been published. Biomarker-based data has shown a rapid increase in blood-based biomarkers indicating potential disease exacerbation when lecanemab is stopped. Based on that rationale, lecanemab has an FDA approval now for maintenance-based dosing after the first 18 months of treatment. This subcutaneous form was matched in its potency to the intravenous form and is available to be completed through the use of an auto-injector in a person's home environment.
In August 2025, the FDA approved once-weekly subcutaneous lecanemab injection for maintenance dosing to treat early-stage Alzheimer's disease following completion of the 18-month biweekly intravenous initiation phase. The new subcutaneous formulation is supplied as a 360 mg single-dose pre-filled auto-injector and is expected to reduce healthcare resources and allow patients the convenience of at-home administration.
Appropriate use recommendations for lecanemab and donanemab are published. These talk about very important inclusion and exclusion criteria, with some of the most important exclusion criteria being individuals who have too much cerebrovascular disease, evidence of prior brain hemorrhage, and the use, particularly, of drugs that increase a person's bleeding risk. There are many other inclusion and exclusion factors, and I would recommend review of these appropriate use recommendations. There are many topics to include in a shared decision-making discussion with patients and care partners regarding amyloid beta-directed therapies. This slide goes over some of the more important topics one might discuss. It is very important to frame what the expected benefit of treatment might be. It's also important to review in terms that patients can understand the risks of amyloid beta-directed therapies, including ARIA and infusion-based reactions. There's a very significant commitment and burden on patients to travel to and from infusion centers, to have individuals who are objectively reviewing a patient's symptoms and actively reporting symptoms that could represent ARIA to avoid complications of treatment. There are significant costs that may be incurred in individuals depending on their insurance plans, supplements, and so forth. It's also important to discuss that these treatments are very new. There are a lot of factors we don't understand that can lead to very serious forms of ARIA, and these uncertainties may help direct patients in making their decision on whether or not they would like to engage in treatment. Another case example here is a patient named George. He's a 74-year-old individual who was referred from primary care after mild cognitive impairment was diagnosed and detected during an annual wellness visit. A mini mental examination was 24 out of 30. He has several medical risk factors. He is currently taking a medicine for hyperlipidemia. A spinal fluid-based biomarker test was performed, which was positive, confirming Alzheimer's disease pathology. MRI findings showed findings consistent with Alzheimer's disease, mild to moderate small vessel ischemic disease, and 2 microhemorrhages. However, George had to be sedated to be able to have his MRI due to claustrophobia. He has 1 copy of APOE4. This case raises several really important points about whether or not George would be a good candidate for amyloid beta-directed therapies. His claustrophobia and need for full sedation for an MRI might prevent him from receiving a rapid MRI should he develop symptoms that would be consistent with ARIA. A need to have rapid imaging is very important so that we can understand what important steps need to be taken or if hospitalization is necessary. He already has 2 microhemorrhages. This meets the appropriate use recommendations, but it may indicate that he is at slightly higher risk of developing microhemorrhages or ARIA in the future. Additional biomarker testing is probably not necessary in George, given that he had spinal fluid biomarkers that were positive. All of these points would need to be part of a shared decision-making model in deciding what the next best steps for this patient. Module 3, Amyloid Beta-Directed Therapy in Practice. This module will address logistical, administrative, and safety considerations of amyloid beta-directed therapies. The clinical implementation of amyloid beta-directed therapies for Alzheimer's disease requires a multidisciplinary team-based approach. Clearly, one of the more important aspects of implementing amyloid beta-directed therapies is the early detection of individuals who have early-stage Alzheimer's disease. For practitioners like me, who work in a tertiary referral neurology clinic specializing in dementia, many of the patients that make it to us have advanced to the point where they are no longer in the early stages of mild cognitive impairment. MCI patients typically present in primary care offices. The ability to find these individuals, evaluate them quickly, determine in a rapid way their eligibility for amyloid beta-directed therapies, and then finding ways to get them to referring specialists quickly so that they can enter into treatment is important. Long wait times in particular impact a patient's efficacy for treatment. All of these things need to be a consideration when you are creating a workflow for identifying these patients and getting them to the right place. As we discussed in previous modules, there is a significant importance in the logistics of treatment, which includes the timing and scheduling of safety MRI scans, monitoring patients clinically for infusion reactions and ARIA, as well as making sure that individuals are registered in important and necessary databases for monitoring in this post-approval phase. Long-term care for individuals who have undergone amyloid beta-directed therapies is also important, and important for all individuals who are diagnosed with any form of cognitive impairment. There are certainly barriers to implementing amyloid beta-directed therapies in the clinic. Creating site-specific protocols and the relationships necessary will all be unique based on a person's practicing environment, their state, their EHR, and their regional health systems. Understanding what the biomarker testing capabilities are for your specific setting will be important. Particularly important will be evaluating the radiology and nuclear medicine capacity for performing and interpreting PET scans, but also ensuring that radiologists are familiar with and able to report out in a specific way that is helpful to the prescribing individual comparisons between baseline MRI scans and treatment-based MRI scans in the detection of ARIA, the monitoring of the number of microhemorrhages, detection of any susceptibility-weighted and flare-based changes that could potentially indicate a treatment side effect. Being proactive about patient safety is important. There may be ways that you can educate individuals on avoiding drugs that might worsen their risk of side effects, including ARIA. There may be ways that you can indicate in your EHR a person is on treatment and alert emergency medicine doctors and others about the importance of maintaining patient safety in those individuals. Finally, an important barrier is the financial burden of treatment. In addition to the cost of medication, there are a lot of other costs associated, including being in the infusion center, receiving the infusions, the scans that are necessary, and a variety of other tests and costs that are associated with treatment. Having an individual who can explain these costs of treatment to patients is very important, particularly in terms that they might understand. Prior authorization and appeals for denial are a part of all newer treatments, especially those that incur quite a cost to the healthcare system. Making sure that we meet deadlines with prior authorization requests are important. Understanding what the important aspects of documentation are so that this can be included in your notes. Preventing requests for discussions with prescribing physicians will save time from both a patient standpoint and a provider standpoint. National patient registries for new Alzheimer's disease drugs are required. There is a CMS-based database that can be used to register patients going on to amyloid beta-directed therapies, and there is also secondary databases, the largest of which is called ALZnet, which is through the Alzheimer's Association. One can participate in one of these registries or both of these registries. At my site, we participate in both, trying to advance the science and our understanding of how these treatments impact individuals. When you're evaluating how patients will get to treatment, there are a variety of websites and apps that may help with that. An example of one is shown below. This is a locator application which helps providers find infusion locations for their patients. These infusion locations likely have some familiarity with amyloid beta-directed therapies, and one can establish a relationship with infusion centers in your locale. Amyloid-targeted therapy infusion order sets are often created by healthcare systems so that all of the safety protocols are followed. Individual infusion centers may have their own order sets in order to maintain safety. Many of these order sets are broken down into specific treatment regimens, where a number of infusions are approved, and then when a required safety MRI is timed, the patient's order sets end, and a new order set begins once that safety MRI is reviewed by the ordering practitioner. Therefore, multiple order sets may be necessary for an individual patient so that safety protocols are followed. There are a wide variety of EHR-based tools that have been developed and are currently emerging. This is an example of an EPIC flowsheet that involves an assessment protocol, a treatment pre-planning protocol, and an infusion therapy order set. Again, the infusion order sets are broken down so that individuals cannot continue to receive infusions until a trigger point of a safety MRI has been reviewed by the prescribing provider. These types of safety net implementations in EHRs are critical to help organize larger numbers of patients and to maintain safety. Going back to discussing ARIA-E and ARIA-H, there are several ways that we look at this, and each of these individual forms of these side effects need to be considered. The severity of ARIA is determined and important in flow sheets, which we will see next. Edema is often seen on flare-based sequences, so having a very good flare sequence that is free from as much motion artifact as possible is really important. And we can see edema within the brain parenchyma itself, but sometimes we can see leptomeningeal and sulcal effusions on MRI as well. Microhemorrhages typically take two forms, and the sequences that are critical for the detection of hemorrhages are the T2 star, GRE, or SWI sequences. On these sequences, we can see microhemorrhages, which often appear as a punctate area that can be seen throughout the brain parenchyma, or a layering out on the leptomeninges of superficial siderosis. And as we will see, superficial siderosis is a very important form of ARIA-H, which often leads to stopping of treatment. ARIA is graded radiographically. These tables are available here on our PeerView presentation, but also present in the appropriate use recommendations for each of these drugs, which we discussed earlier. Mild, moderate, and severe-based grading scales show criteria here and are very important for decision-making in terms of redosing or termination of treatment. The ARIA monitoring schedules are also published in the appropriate use recommendations. The monitoring schedules are different for lecanemab and donanemab. What this means is that one may have to have two different order sets for these medications, and in those individuals who have EHR-based triggers, these will have to be different between the two medicines as well. We can see on lecanemab that there are MRIs prescribed before the first infusion, at the 5th, 7th, 14th, and follow-up scans for selected individuals. Whereas for donanemab, there are scans that are done before infusions, after the 2nd, 3rd, 4th, 7th, and in selected individuals further on. This is due to the difference in ARIA-based side effects and the experience from the phase 3 clinical trials. Computer-aided detection has become very important. We now have software packages, which we alluded to, that can help with the detection, not only of the amount of plaque that's present in the form of centiloid values, but now there are packages that can help with the identification of ARIA-based events. These software packages have all of a patient's images uploaded so that direct comparisons by computer-aided detection means can be made to look for subtle differences, which could indicate small amounts of amyloid-related imaging abnormalities, and to help with improving the safety of amyloid-beta-directed therapies. These software packages may or may not be available with your radiologist, and so checking with them and understanding what the limitations are, or perhaps advocating for the inclusion of packages like this, could help with your safety and your patient's safety. The clinical management of symptomatic ARIA is also described in appropriate use recommendations. Again, most ARIA is asymptomatic and found by MRI surveillance. However, recognizing and making sure that patients understand what the most common clinical symptoms are could help with detection in the interim between scans. Those most common symptoms involve headache, visual changes, confusion, apraxia, and so forth. When a patient exhibits these types of symptoms, one may consider pausing treatments and obtaining a non-prescribed MRI scan to look for the possibility of ARIA. ARIA typically resolves spontaneously and can resolve spontaneously with or without withholding of treatment, depending on the clinical circumstances. Severe ARIA is possible and can involve seizures, encephalopathy, and focal neurologic deficits. In individuals exhibiting these types of side effects, one often refers to an emergency level of care and may require hospital-based admission and monitoring. IV steroids, including methylprednisolone, have been reported to help with symptoms and may be necessary to limit the amount of edema present. Ensuring that emergency department personnel are educated on ARIA, typical symptoms, and how severe ARIA can masquerade as a potential vascular event. Making sure that safety systems are built and in place to avoid the use of thrombolytics in individuals taking amyloid beta-directed therapies is very important, as the deaths that have occurred on treatment have often been in the setting of thrombolytic therapies. ARIA management algorithms have been proposed. Many of these are included in the appropriate use recommendations. This is an example of an ARIA management algorithm. Firstly, one needs to know if they are symptomatic or asymptomatic. Follow-up with patients after detection of ARIA and collection of these symptoms are very important. Once again, ensuring that candidates for these therapies have a very good informant, someone who knows the patient well and can understand if there's been a change in their symptomatology or clinical presentation, is critical to choosing patients that would be eligible for treatment, and then being able to be a part of decision-making in terms of what happens after ARIA is detected. Making sure that there's a clear pathway of communication from radiology to the referring clinician is important. When ARIA is detected, that information needs to pass to the provider quickly so that subsequent infusions can be stopped if necessary. Indicating to the rating radiologist that an individual is on amyloid beta-directed therapy is very important. Specific radiology-based templates are available through the American Board of Radiology, and ensuring that templates are used to help with the ease of reporting is necessary, and to ensure that that communication is rapid. Communicating also with patients and infusion centers is important, and having an important structure in place so that these communications can be executed quickly and effectively is important for patient safety. Emergency department teams, as we alluded to before, is critical in ensuring that thrombolytics are not given to individuals who are actively being treated with amyloid beta-directed therapies. Educating emergency department personnel about the clinical symptoms of ARIA is very important. Ensuring that emergency department personnel understand that most forms of ARIA cannot be detected on a plain head CT is also important, and that they might choose to move to a rapid MRI when a patient on therapy presents could be an important factor in decision making. Ensuring that emergency department physicians are equipped with the knowledge to get information about whether or not a person needs admission or rapid treatment is also important. Navigating vascular events is difficult. Again, some forms of severe ARIA can present as a stroke mimic. Educating patients about this, potentially using additional wallet cards, bracelets, or other indicators, making indicators in the EHR are also important. We educate patients that if they are having stroke-like symptoms, going to an emergency department is critical because mechanical thrombectomy, without the use of thrombolytics, may be an important therapy that can be used in the setting of amyloid beta-directed therapy. In individuals who develop new atrial fibrillation, have new DVT or PE, or clots associated with stroke, having a shared decision-making risk-benefit discussion about the use and initiation of anticoagulation is important. Many patients are reluctant to stop their amyloid-targeted therapies, and having a discussion and close relationship with the prescribing provider will be important as a part of this decision-making. Again, there are ways that we can improve patient safety. Wallet cards are important so that patients can present at emergency departments that they are on amyloid beta-directed therapies and that they should not receive TPA or TNK. Many individuals will wear identification bracelets describing that they have Alzheimer's disease and they are under treatment with a drug that can increase their risk of brain edema and bleeding. EHR alerts are important so that when an individual attempts to prescribe a thrombolytic, a warning box is able to be displayed which indicates that this could lead to a life-threatening side effect. Each EHR and system is different, and I would encourage you to look into the ways that your institution can improve patient safety through EHR changes. Now we come back to patient 2, George. Ultimately, George decided to initiate amyloid beta-directed therapy in conjunction with his providing physician. About a week after his 5th infusion, he developed a headache and blurry vision. This is an important discussion and raises several discussion points. So, discussion point number 1, how does the onset of these symptoms change or otherwise affect his ARIA monitoring schedule? In the setting of an individual who develops symptoms that could be clinical symptoms of ARIA, one would want to have an urgent, unscheduled MRI to look for the possible development of ARIA. Particularly within the first 3 to 6 months, ARIA is much more common than when later on in treatment. Therefore, after the 5th infusion, this symptom constellation could absolutely represent new ARIA that may not have been seen on a previous surveillance MRI scan. Pausing infusions until the result of this MRI is completed would be an important consideration. As a part of participation in the CMS registry and/or in ALZ-NET, reporting of ARIA events is very important for post-approval monitoring. In an effort to try to improve patient safety overall as these drugs become more commonplace, making sure that these databases are updated and accurate is very important for future patient safety. Finally, when an individual, assuming that George had an ARIA event, we need to have shared decision-making as to whether or not George would continue on treatment. If he had minimal symptoms that resolved quickly in a small amount of ARIA-E that resolved over the course of a month, one may consider treatment reinitiation. However, if the ARIA symptoms are persistent, if there is a large area of ARIA, if there is a rapid accumulation of microhemorrhages, if there is accumulation of superficial siderosis, continuation of amyloid beta-directed therapy may not be in the patient's best interest because it could indicate a future ARIA event that could be more severe. Making sure that patients understand what the ARIA appears like, what your own personal concerns are, will help them make decisions because many patients are driven to continue therapy to treat their disease, and making sure they understand those risk benefits are very important. Key takeaways from this peer review discussion include we need to make sure there is timely detection and diagnosis of Alzheimer's disease before the onset of dementia in that mild cognitive impairment range, when we know that amyloid beta-directed therapies are most efficacious. This is a very critical point and one that requires partnership with primary care and other individuals who may be able to refer individuals at the earliest stages of treatment. Increasing the availability of disease-modifying therapies is very important, and creating the infrastructure within your locale is very important for future Alzheimer's disease treatment. We now have FDA approval of the first plasma biomarkers. And as we learn more and validate these biomarkers in a variety of clinical settings, this will hopefully allow us to make an earlier biomarker diagnosis and open up treatment possibilities to a greater number of patients. Amyloid beta-directed therapies represent a promising breakthrough in the treatment of Alzheimer's disease patients, and recent publications have shown 3- and 4-year extension data, which is promising, showing a distinct and growing difference between those treated with amyloid beta-directed therapies and those who are not. Safety and appropriate management is absolutely critical to ensure that these treatments are given to the appropriate patients and that we don't miss important adverse events that could be related to treatment. This does involve selecting appropriate patients, heeding the warning signs for early detection and management of ARIA, and coordinating closely with multidisciplinary teams. Thank you again for your participation in this PeerView production, and we hope that this is helpful in the implementation of amyloid beta-directed therapies in your locale.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant by Eisai Inc. To access all materials for this activity, visit peerview.com/CXX860.